Here. I'm Antonella Campodolorto from IPAD Italy, which is Association of Patients with Adrenal Disease. And
I am Heidi from the Danish Adrenal Association, and we would like to present Jenny Brown from University of London, who has made a survey on factors associated with self-management and prevention of adrenal crisis.
So, thanks to all. At the end, you can make questions. There is a microphone over there for any questions related. Thanks very much.
Hi there. My name's Dr. Jenny Brown. I'm from City St George's, University of London in the UK. Today I'm going to be talking a little bit about some data that we've collected looking at the prevalence and outcomes of adrenal crisis in adults with adrenal insufficiency, and that's a UK survey. So no conflict of interest. So adrenal insufficiency is characterised by not being able to produce enough cortisol, which is an essential hormone for the body. So people with adrenal insufficiency need lifelong cortisol replacement treatment. They're also at risk of adrenal crisis, which can lead to hospitalization and can be life-threatening. So impact on patients and the health service, the estimates are that 1 in 6 to 12 people are hospitalized every year from adrenal crisis. And unfortunately, 1 in 200 die from adrenal crisis. So that's about 5,500 to 10,600 deaths in the EU. So people with adrenal insufficiency tend to report an impaired quality of life, and there's a high prevalence of unemployment as well. So looking at the bigger picture, another risk factor for developing adrenal insufficiency is being on high-dose corticosteroids for a long time. So 1% of the population do take high-dose corticosteroids and therefore at risk of developing adrenal insufficiency and having adrenal crisis. So self-management strategies are crucial for people that live with adrenal insufficiency. So there's sort of 3 main areas. The first is daily replacement with glucocorticoids, and for people with primary adrenal insufficiency, so that's where the adrenal glands are affected directly. They also need mineralocorticoids as well. So the second area is something which sometimes people call sick days. So if people are physically unwell or under a lot of stress, for example, or some sort of psychological illness, you need to adjust the glucocorticoids. So typically, people might, for example, double the dose that they would normally take during these so-called sick days. And the third area of self-management is to do with prevention and management of adrenal crisis. So essentially, by understanding and addressing self-management needs, we can optimize, hopefully, well-being, quality of life, and treatment outcomes. So the data that I'm going to show you today is the UK part of what will eventually be an international survey, which I'll tell you a little bit more about at the end. So what we were after was to look at barriers and enablers to self-management in adults with adrenal insufficiency. And it was a large online survey where the 3 main areas, one was the management of daily replacement, so-called sick days and adrenal crisis. We looked at self-management behaviors and adherence to glucocorticoids using validated scales. And finally looked at patient education and service care provision. So the recruitments from patient advocacy groups, or PAGs, and endocrine clinics, so far, because we've just done the UK survey, we've had 3 patient advocacy groups in the UK and 28 NHS endocrine centres. So in total, we got 1,789 participants, it's just a large sample in this area, which we thought was really good. And then the next stage will be a very similar survey to go out internationally. So just a little bit about demographic characteristics of the people that completed the survey. So there's a sort of spread of ages, but if we're looking at comparing the NHS group, so it's about 1,000 people from the NHS endocrine centres and about 740 people from the patient advocacy groups. Tended to be that the people from the PAG groups tended to be a little bit younger. Not quite sure why that is. It might have something to do with how we did the survey. So we started out with the PAG groups, and that was all online. And was advertised, I believe, mainly online through sort of like newsletters and emails and things like that. So it might have sort of narrowed into people that were perhaps more familiar with like online surveys and online technology. Whereas with the NHS group, we provided a link online, but also we provided hard copies as well. So that's, I think, an important consideration going forward is the recruitment strategies and how we can best make it so that everybody can participate. So demographic characteristics, we've got predominantly female, about 2/3 of the people that completed, the rest, about a third, male, and a small minority identified as non-binary. So again, we had differences between the PAG group and the NHS, and in the PAG group tended to be more females compared to males. So in terms of diagnosis and type of adrenal insufficiency, so as you can see on the left, hang on, I've got it right, this one. The type of adrenal insufficiency, so we've got roughly equal proportions of people with primary adrenal insufficiency and secondary adrenal insufficiency, and then a smaller numbers of people with tertiary, and a much smaller number of people who did not know the cause of their adrenal insufficiency. So again, slight differences between the NHS and the PAG groups tended to be that the NHS group had more people with primary adrenal insufficiency, and the PAG group had more people with secondary. Also, I will come back to this in a second, but just to point out that there's quite a few people that didn't know what the cause of their adrenal insufficiency was, and that was different between the PAG and the NHS group. So in terms of years since diagnosis, almost half of people diagnosed for more than 10 years ago. So we had relatively few people that were diagnosed either less than a year ago or 1 to 2 years ago. So coming back to this, this category of not knowing what the cause of adrenal insufficiency was, this graph is essentially showing you what the numbers look like before we recategorized some of the free text things that people had said, and the light blue is after categorizing. So what happened was, this is just for the PAG groups, we asked, what is the cause of your adrenal insufficiency? And there were 4 categories, so condition which affects your adrenal glands directly, so that's primary, condition affecting your pituitary or hypothalamus, which is secondary, and long-term treatment with high-dose steroids, which is tertiary. And then the 4th category, I'm not sure. And if people weren't sure, there was a free text box where they could write down either what their diagnosis was or what they understood to be happening. And what we found is, actually, if you went through the free text that people wrote down, we were then able to categorize into primary, secondary, and tertiary based on what they'd written. So I think there's something important there, maybe perhaps something to do with communication with patients, is that people did tend to know, what their diagnosis was, but had difficulty in categorizing them in primary, secondary, and tertiary. So glucocorticoid replacement, as you can see from this table here, most people were on short-acting hydrocortisone. Then the next biggest group is prednisolone. In case you were wondering, there was a relatively small number of people on FMODI, the long-acting hydrocortisone, and that's because when the survey was done, it was relatively, it pretty much only just come out, so I don't think that many people knew about it, but I think in the international survey, we'll probably see more people on that drug. So dose frequency, most people took their drug 3 times a day. Again, slight differences in that people in the PAG group were more likely to take their medication 3 times a day compared to the NHS group. They also had a slightly higher dose, total dose per day compared to the NHS group. So in terms of adherence and beliefs about medicines, we had a look at these sort of health behaviour psychological factors, which I think is quite unusual in this area. First of all, we had a look at adherence, so how people are able to take their medicine as prescribed, basically. So do they take the correct dose? Do they take too much, too little? Do they take every single dose? Do they sometimes miss their doses? Things like that. This is obviously like self-reported from the people taking the survey. So as you can see, the scores here, they're actually really high, which is good because the maximum on this scale is 25. So again, slight differences in that the people in the PAG group scored slightly less for adherence compared to the NHS group. And then we've got beliefs about medicines. So these are beliefs about daily hydrocortisone replacement. So the beliefs about medicines scale has two subscales, basically. One is called concerns. So concerns is things like you get a statement, for example, having to take hydrocortisone worries me, having to take hydrocortisone disrupts my life, things like that. And then people have to say whether they agree or disagree with the statement. And then we've got the other subscale, which is necessity, which looks at how necessary people believe their medication to be. So these are statements such as, my health now depends on hydrocortisone. Without hydrocortisone, I would be very ill, for example. And as you can see, again, we had differences between the different groups. So the people in the PAG groups scored slightly higher for concerns about their medicine. And for the necessity scores, which were both very high, which is good because the maximum is 5. So everybody essentially thought that their medication was highly necessary. And again, the PAG group scored higher for the scores in necessity compared to the NHS group. So in terms of prevalence, so for lifetime prevalence, have you ever had an adrenal crisis? More than half people had an adrenal crisis at some point. But when we have a look at whether having an adrenal crisis led to diagnosis, we've got about 29% of people, that was the case for them, and about 2/3 it wasn't. So interestingly, with the lifetime prevalence, there's 9% of people who actually weren't sure whether they'd had an adrenal crisis or not. And again, this might have implications for patient education and understanding. So in terms of adrenal crises in the past year, so we've got about 2/3 of people had no adrenal crisis in the past year. Then we've got 17% of people had 1, 8% of people had 2, 4% of people had 3, and 3% of people had 4 or more adrenal crises. So overall, 32% of the sample, so that's 561 patients, had at least 1 crisis in the past year. So then we asked them a little bit about preventative measures and tools that people use or not for adrenal crisis. So as you can see that this is the NHS steroid emergency card. There's a slightly different version of that as well, and we also asked about whether they had an EU emergency steroid card as well. In terms of carrying the card, it seems that most people were carrying the card and there wasn't any difference between the NHS and the PAG groups. In terms of wearing the medical alert ID, so it tends to be jewellery like a wristband or a necklace, we've got more people in the PAG group, 75% of people wearing medical alert ID and less people in the NHS group. Most people tended to have an extra stock of hydrocortisone tablets. Again, there were differences. The PAG group were more likely to have this extra stock. In terms of possessing an emergency injection kit, again, slightly more people in the PAG group possessed an emergency injection kit. Now, I think this is probably the most important thing, is that we asked them, do you carry your emergency injection kit at all times? And 61% of the people in the PAG group said yes, but only 47% of people in the NHS group said yes. So then what we did is we had a look at various demographic, clinical, preventative tools, psychological factors, and we looked at them one at a time to see if they were associated with having had an adrenal crisis within the past year. So when we were looking at adrenal crisis in the past year, we just boiled it down to have you had none or have you had one or more, so it's a binary measure. So just to be aware, though, that obviously this data is looking in the past, so we can't say anything about cause or future risk. We're just saying these are the factors that are associated with what people reported to have happened in the last year. So adrenal crisis was less likely with older age. So the group that was most likely to have had an adrenal crisis is 26 to 35-year-olds. Females were more prone to having adrenal crisis. Patients receiving disability living allowance were more at risk of having had an adrenal crisis. So in the UK, basically, if you're unable to work because of illness, then you can claim money, like social security kind of thing, disability living allowance. ECE was more likely in patients with tertiary adrenal insufficiency. ECE was less likely with increased years since diagnosis. So that kind of makes sense in that the longer you've been diagnosed, the less likely you are to have an adrenal crisis. So presumably you've had longer to get to grips with management. The group that was most prone was the people that were diagnosed within 1 to 2 years. So again, adrenal crisis was more likely for people that carried an injection always, and if they were self-trained to inject and knew other people that were trained to inject them. So for example, partners, family, friends, carers. Also people that wore medical alert ID were more likely to have reported having an adrenal crisis in the past year. So obviously we're not saying that if you always carry your injection, that's somehow going to mean that adrenal crisis is more likely. It's probably the other way around, in that if you have more adrenal crises, you're probably going to be better prepared for the next one. So again, adrenal crisis was more likely, this is the psychological factors here, if people reported higher concerns and higher necessity for daily hydrocortisone. Not surprisingly, adrenal crisis was less likely if you adhered better to your medication. And finally, adrenal crisis was higher in people with a hydrocortisone equivalent dose of greater than 25 milligrams. So factors that weren't associated with the prevalence of adrenal crisis, when you consider them each one at a time, we've got whether you live alone or with others, the type of glucocorticoid that you're on, so either hydrocortisone or prednisolone or some of the other smaller categories that we put together. Whether you had an emergency steroid card, having extra hydrocortisone tablets for sick days. So that's not to say that, there's no point in having the emergency card because it doesn't make any difference. That's not what we're saying here. It's just that the picture is probably a bit more complicated than this, and that these items might only help when they're combined with other interventions or behaviours. So just to say also that if you go to Sophia Lahan's talk on Tuesday, she's going to be talking a little bit more about this data, because when you sort of put everything together, I did mention that was looking at each factor in isolation in turn. But when you put everything together, the picture is slightly different, okay? So in terms of management of adrenal crisis and hydrocortisone injection behaviours, so 3/4 of people said yes, they were in possession of an injection kit during the most recent adrenal crisis. And of the people that were in possession of the emergency injection kit, 90% of those people carried it with them all times. So in terms of who injected you in your most recent adrenal crisis in the past year, we asked people to describe essentially what happened if they injected themselves. So 18% of people who injected did it themselves without any assistance. Then we've got this orange section, which is sort of needing assistance from someone within the community, so whether it's someone in your household or from GPs or community nurses. 20% of people had their injection administered by ambulance crew, and 23% of people went to A&E, accident and emergency, and had their hydrocortisone there, either by injection or drip. So in terms of management, when we're looking at the emergency response, if people called an ambulance, the time from injection to the time from calling an ambulance to receiving your injection, about 50% of people waited less than 30 minutes, which is good. But unfortunately, people that went to A&E, there was a quarter of people waited more than 2 hours, which is a long time to wait for the injection. So in terms of hospitalisation, if you want to know more about this, please come and see me later at the poster session. This is looking at who injected you and hospitalisation rates. So if you self-injected without any help, assistance at all, your admission was 58% of people were admitted to hospital. And then it goes up sort of, I guess, as time goes on. So if you had community assistance, so that's either family, carer, GP, community nurse, then the admission rate is 66%. Then when we get to the emergency assistance, so it doesn't matter whether you're in an ambulance or whether you go to A&E, most people, so 92% of people were admitted to hospital. So who administers the injection does matter, and these were significant differences. So more on the results of the UK survey. As I said, you can come and see me and ask more questions. My poster's looking at adrenal crises, and then we've got Dr. Sophia Lahana's oral presentation on Tuesday, which is part of Symposium 12. So I'm going to end with a plea. We are about to launch the international survey, as I mentioned. So if you would be able to help, because we need to be able to disseminate that survey to people, this is adults with adrenal insufficiency, we'd be really grateful. You can either scan the QR code, which will bring you to a short form to take your email address and name and things like that, or you can send us an email on adrenal.study@city.ac.uk. Thank you very much. So are there any questions? Yeah. Oh.
Hello,
Hi.
I'm Stina Borsen from Copenhagen, Denmark. Thank you so much for a very nice presentation. I was just wondering, in your category of tertiary adrenal insufficiency, you have your glucocorticoid-induced.
Mm-hmm.
Yeah.
Yes.
And you found those patients to have a quite high risk of adrenal crisis. Mm-hmm. Did you see an explanation in your data? Like, was it a patient with that had an adrenal crisis when they were diagnosed, or a short duration? Because there are also the group of patients that might have only partial suppressed adrenal function. So,
yeah.
Did you see anything in your data?
We didn't specifically look at that, but I think we can go back to the data. It's a good idea, actually, and look at characteristics of people with tertiary adrenal insufficiency, because like you said, it maybe they were fairly recent with diagnosis or something like that. We can go back, but there's only because of the way that the survey was structured, there's only sort of so much we can get out of the data essentially. But I think that's a good idea, and we'll go back and have a look at that. Thank you.
And just, if I may, a quick second question. You are you had these nice data on self-injection. Did your data set also include like patients' management with oral tablets to prevent crisis?
Yes.
Did you have data about that, and if they were able to administer the dose themselves? And
I haven't presented it, but there's like a huge amount more data than what I presented just now. There was actually a self-management survey which has the 3 sections about sort of daily management, sick days, and adrenal crisis management. That will be forthcoming in a paper later on, because it was a sort of a fairly new scale that had been developed based on another self-management scale, but adapted for adrenal insufficiency. So Sophia actually developed that scale specifically for adrenal insufficiency, but we're still number crunching at the moment, but that will be in a forthcoming paper.
Thank you.
Okay.
Olle Kempe at Karolinska Institutet, Stockholm. You didn't mention anything about salt. According to my clinical experience, people with primary adrenal insufficiency, with recurrent adrenal crises, they usually avoid sodium chloride and can easily be treated with some extra salt. And for all veterinarians, you have 3 things you need to take if you have, as a dog, you know, it's common in large poodles and in Portuguese water dogs. They get hydrocortisone, fludrocortisone, and a piece of salt that they can lick on. And as physicians, we quite often forget about the salt.
Again, there's loads more data than what I presented here. We did also ask about fludrocortisone separately for people with primary.
But that's a different thing than taking sodium chloride.
Oh, okay. We didn't. I don't think we measured whether people took sodium chloride.
And I think that's a pity that we don't. There needs to be more awareness about salting extra.
That's interesting. I'll tell Sophia that, and we'll make sure that we've got something about that in the upcoming survey.
Okay.
Thank you.
Tânia Bachega from Brazil. Thank you very much for this very nice presentation. Just to share our experience. Other problem that you have to face during adrenal crisis is the way that healthcare professionals deal with adrenal crisis during infection. In the last 30 years, 48 patients passed away since the health professional in a ER refused to give hydrocortisone. And the patients had emergency cards. And I am thinking how to educate health professionals in the unit cares in a country with a continental extension. And do you have a similar experience?
Yeah, very similar. We don't have quantitative data on that, but at the end of the survey, we allowed a lot of space for people to just write other comments, things that they wanted to say. And it was very interesting because there were quite detailed accounts of people's experiences. Generally in A&E, similar story, is that, people saying, I arrived to A&E, I explained what was going on, showed them my card, everything, and then waited ages, and then like, oh no, but we have to get a doctor to do this, and then there was no one available. And so this kind of is explaining that possibly why people tended to wait longer in A&E, because I think, and that's something that we need to take into consideration, something about the triage system or something about understanding of adrenal insufficiency is lacking, and that is not treated as the emergency that it should be. So very similar, and that's another area that we're actually looking at as well, is people's experiences in more detail about going in the ambulance and A&E. So yeah.
Øystein Huseby from Bergen, Norway. Thank you for a nice presentation. You didn't mention how adrenal crisis was defined in your survey. There's no uniform definition,
Yes.
so I wondered, how did you define it?
That's a very important point. As far as I understand, because I joined the project after this survey had already been completed, as far as I understand it, on the earlier drafts of the survey, they did actually have a definition of adrenal crisis. But then after consultation with patient advisory groups, they actually took that out. That was because, as you said, there's different definitions, and they were worried that that might exclude people that didn't really exactly fit into the definition that they were going to give. So actually in this survey, there wasn't an official description, I suppose, of adrenal crisis. And I think that might be a limitation of the data as well, in that I think possibly some people, if they didn't know what adrenal crisis meant, but then if there was a description, they might think, oh yeah, that happened to me. So that might explain why some people actually didn't know whether they'd had an adrenal crisis or not. So I think this is going to, again, we've learned quite a lot from the UK survey. This will be addressed in the international version.
I think you might risk over-diagnosis of crisis if
that's true.
Up to...
it's difficult because either you need to give the information so people know what you're talking about, but then it's like, it's hard because it's obviously self-reported as well. Yeah.
Good morning. My name is Johan Beun. Thank you very much for your talk. I appreciate it. I would like to address to this Brazilian lady and to all the others, we should train the patient to inject himself or herself, because we in the Netherlands and with the old program of AdrenalNet, we had the saying, jab first, talk later. If we don't jab in the beginning, you get serious problems in a Belgium ambulance. You get serious problems in a British A&E because you get a new doctor. You get serious problems in Germany. So if you don't jab first, you don't have these 3 to 4 hours to negotiate with a doctor what the serious problem is. So if it comes to guidelines, please, 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 jab first, talk later. Thank you very much.
Thank you. Yeah, that is essentially the main takeaway from our findings, is that there is actually evidence saying that if you do manage to self-inject, and obviously that means that you're injecting as soon as you possibly can, it does make a difference for hospitalization. Yeah.
Hi, I'm Helga Sirensdottir. I'm from Iceland. When I was working at Sahlgrenska University in Gothenburg, we started making these cards over 20 years ago, and then they moved to other countries, and now we have a European card. And I'm sorry to see that the NHS has their own card, because this is a small population of patients, and it's really serious if they get sick on a hotel anywhere in the world. I tell my patients, you have a bag with your injections so that you have your card in, and if you need to call the lobby for assistance, they will see it right away when they come into your hotel room, for example. I think that this is a matter that we, working in Europe, need to work on together. It should be something maybe that the ECE should take to their account. We are having information from Belgium. They made beautiful videos for the patients, how to inject and so on. And this is something that we should work on in collaboration in Europe, I must say. But thank you for your study. It's wonderful to have some information to take home. And for the ambulance personnel, not the least. Thank you.
Thank you. Hi.
Stefanie Hane from Würzburg in Germany. So thank you very much for this nice study. I also agree that self-injection is very important and enables the patients to treat themselves early. The difficulty is that we have not a nice injection kit, so that's one difficulty. And if we talk to pharma companies, then they say, oh, there's no business case because it's so rare, so they don't want to develop something like that. And I found your data interesting, showing that the patients who performed self-injection had a lower number of being treated in the hospital compared to the patients who were treated by emergency and health professionals. And that's what we saw also in another prospective trial, when we found that those patients who performed initial self-injection, that they were more frequently treated as outpatients compared to others. The questions would be, and that's what we also find a little bit in our we have now a long-term follow-up of our initial prospective study published several years ago. And but I think we need arguments to just demonstrate that performing self-injection really prevents hospital treatment and prevents mortality, but particularly prevents hospital treatment. And therefore, I would like to know if you collected also data on the severity. So maybe these patients who were treated as outpatients or who performed the self-injection were in a better condition, then this would somehow be argue.
I think that probably was the case, because for people that didn't manage to self-inject, we asked why, and actually the top reason I was too unwell. But there was actually sort of quite a few people who also said they just preferred a healthcare professional to do that. And what we found, if you come and see my poster later, I'll tell you a bit more. We also looked at, we asked people their confidence in self-injecting, and not surprisingly, people that self-injected had higher confidence and also were more likely to have been trained in giving injection, which kind of makes sense. And we also had another question, which I'm not presenting in this conference, but we also did have a question which was of hypothetical, that if you had a injection that was more like an EpiPen, which didn't need mixing first, how do you feel about that? And everyone was very, very positive and felt a lot more confident that if they had much easier to use mechanism, then that would be really helpful. So that was also really apparent from the findings.
Yeah, there was already call for action, but I would also call for action for having such a pen.
Yes, I believe it's in development, but I'm not sure where they've got to with it. But okay.
Thank you very much.
Thank you.
I don't think anyone has any more questions, so we will say thank you very much for participating in this workshop. Thank you, Jenny.
Thank you. Thank you.